full years, which was such an honour. And in that time, there were 2 audits of the work in birth afterthoughts in the NHS. And the results of those were very good in terms of the way that I work with people. There's a very specific way that the service evolved, and we didn't have lots and lots of sessions for people. So that was complicated. But the audits showed up things, like 2 audits showed up, the level of depression that mums have really, and sometimes that brings people to suicide ideation, and both of them almost were equal, you know, for 50 clients. That was the same for both of the audits, and that was something to bring attention to, really, that depression is very important to treat properly. We have 3 counselling students at the moment, and we also have 3 therapists, including myself, that work with birth trauma. So this is Aoife Lyle. I found this book. It's a book of poetry. She's not just writing about being a mummy, which is good, but she has suffered grief in her journey. And I just like this poem because, I'll say it at the end, I suppose, but the room is awash with paediatricians and surgeons. They cut and stitch like fishermen, gut and clean their blue-green sea. Your skin, the baby, still salmon pink from the struggle. And when he kisses you for the first time, all at once, his eyes fill with the knowledge of the whole world in his hands. So she's talking about her husband, and he's receiving the baby, and this is the response. And I just felt she's almost not there. She's an observer of what's happening in the action that's happening around her, and observing very well, and can write about it beautifully afterwards. And very often, a lot of the time in birth trauma, that people feel that sense of isolation and a sense of observation of what's happening in and around them. So yes, there is a birth trauma crisis, and there's so many different reasons for that. I do think there's a lack of understanding in medicine and midwifery of trauma, that we go through a whole birth experience with parents, and we're not really aware at this point in our professional lives that that's where the trauma would happen. And after I had started working with people who were traumatized, I was going back into the clinical environment and going, I wouldn't know where in this journey this person would have felt that birth journey to have been traumatic unless it was a rush in an emergency. And a lot of the time, trauma isn't about a rush and emergency. Sometimes it's about a lack of inclusion of trauma responses in emergency procedures and training, that we forget to look after the reality that the person has become afraid while these emergency procedures are happening. It can be lack of due care after the emergency procedures, that we don't go back and explain or realise that that was quite an experience for the mother who has gone through that. And sometimes that's something that's really important to look at. Lack of inclusion of mental health questions and antenatal assessment. I know we do ask about depression, we ask about anxiety. We don't necessarily query the idea of birth trauma experience in a previous pregnancy. And it's worth for mums just to know that it's really important, maybe that's put down in your notes, that it was traumatic, and maybe that there are some things that would make it better for you the next time. Mum's symptoms of trauma are unrecognised or misdiagnosed, mostly PTSD. In my experience, when I'm working with people who have PTSD, it has been often unrecognised in the medical system, and they're being treated for anxiety, but not for actually the symptoms of trauma. There's restrictions due to the definition of birth trauma as PTSD, because you have to have so many symptoms to be diagnosed as PTSD. I think post-traumatic stress symptoms is probably more common and a probably more helpful term to diagnose birth trauma as such. So we treat PTSD and as anxiety alike in Afterthoughts NI if a mum has had a traumatic birth, and at the Afterthoughts NI model of care, which I'll talk about in a moment, Because the anxiety is linked to the birth trauma, if we treat those symptoms, then hopefully that will ameliorate that sense of anxiety and stress. Comorbid depression linking to a traumatic birth can happen. Sense of not being happy with what happened, or a sense of just the actual arrival of depression, I think, is very complex sense to parents, because you expect a baby, you expect happiness, you expect a link and connection with your baby, and sometimes that depression can be very isolating and uncomfortable. And I think it's when it's associated with a traumatic birth, it is a little bit more complicated in terms of treatment, because there's such an emotional cost there. Research evidence on long-term effects. So there is a lot of research there that it affects mommy, it affects communication with baby, and therefore it can affect developmental concerns with baby, and it can affect partner relationships too. This is the way that I work. I'm not going to go through it all. I am saying that anybody who is a therapist and trained to work with people in terms of counselling, I'm happy for you to use this. I'm not happy for you to print it and go on with it, because I think it needs a little more action. I think the first and most important thing is that trauma education and a variety of tools are there for parents to work with who have found that birth experience to be traumatic, because those symptoms are very uncomfortable and not necessarily part of the control that you can exert in life. So that first session is really important. It's important not to go into the full details sometimes of the birth experience. It depends on the individuals. So I'm not going to go through it entirely. It's not really what I'm here for, but it's just to say that there is a real importance in any work in counselling that the person in front of you understands why did this happen, in the sense that these symptoms are in my body, in my mind, and I wasn't expecting that at all. So learning about a trauma response is really important. Working with birth trauma memories is really important. And in the narrative between my clients and myself, I'm looking in that communication for trauma responses in the narrative. And mums will be looking internally to see, yes, I feel a tightness in my chest, or my tummy's going over in knots as I'm talking about that. And that's really helpful to know. I use Rewind, I use trauma-focused CBT, and I use EMDR for processing or reprocessing memory. And I'll talk a little bit more in later about why it's important, that word reprocessing, because it means a lot more than getting better. It just gives your mind another way to work with what is the truth of what has really happened, and that's important too. So these are just symptoms, PTSD and PTS symptoms, emotional symptoms, physical symptoms. Use talking therapy and those different ways of working. A long time ago, this gentleman coined the phrase, what wires together, fires together. And as we've looked at how the brain works, it is really important to understand that that's true, that if you have fearful past, and a lot of people have a fearful past, whether that was through bullying or sometimes through just complicated relationships with parents, domestic violence, all kinds of things can have happened that have created neurons that fire in a particular way. So birth trauma tracks the birth experience for trauma responses when we're working. Emotional trauma is much, much harder to process and takes time, so that if you have an internally terrible sense of disappointment in yourself, that might be something that takes a little bit more time, because there's a lot of the work will depend on what the mum or dad are doing for themselves, and it becomes a skill then that you have the rest of your life. Physical activities that prevent a trauma response. And I suppose I'm asking, how many do you use? Do you even know that there are things that you can do in a labour experience, in a birthing experience, to make sure that that firing of terror or fear that you've just shot out of, whatever restful place that you're in, and feel that you're in danger, then realise you're not. And how do you bring that down so that it's not still in your system 12 hours later? This is an example. Fear responses in labour, they tend to be hidden. They really do. I wouldn't know that you've become terrified. It's unseen by the professional. Fear moves in an active birth scenario to managing the next contraction. So you don't have time to think, I was afraid and I have to breathe through my contraction. So you're still using your Antonox or your Remery, your experience of switched on fear response, unnamed. Nobody said that's a fear response. You don't know it was really, because you're forgetting about that and doing the next few moments. But your brain is still reading the room for danger. Everything in a fear response slows right down. People will think that moment lasted for 10 minutes and actually it was 10 seconds. Mom is looking for danger and reassurance because she feels afraid. And the hippocampus, which is a part of the brain, reads the room. It's looking around all the time to make sure that you're okay. And the amygdala is saying fear because of the hormonal change in your body. And this memory is alive and it's difficult to process until later. It's not really possible in labour. Telling the story will bring that same fear to life. So you track with parents what's happening in their bodies whenever they're talking about fear. So do you have the skills at the moment as parents, as professionals, to help parents to ameliorate or to deaden or to lighten that response? And would you know that it happened if you were in labour and you felt afraid afterwards? This becoming afraid repeatedly can happen multiple times in a birth journey. You're not just looking after you, you're looking after your little person, and you're handing over quite often the care of that journey to a system, and that can be very complicated psychologically. Not the best little diagram, but I like it because it's bringing a couple of names to the system. Some of the limbic system ones, you've got lots of other parts there. And I only really talk, and any of my clients will know that, really about the amygdala and the hippocampus. The fear response starts in a region of the brain called the amygdala. It's a very small, you can see it here, it's just got a little a little almond shape there to it. And sorry, I'll do that there. But it's a potent place in the body and gives a lot of information. That's really important. It also does lovely things that help you to fall in love. There's bodily changes, though, that occur and prepare you to be efficient in danger. And if you're not in danger in the sense of needing to do anything about it, those bodily changes are a lot of hormonal responses in your body. The hippocampus and prefrontal cortex help the brain to interpret the perceived threat. So you may not be in any danger, but the perception that you are may bring you to that place. So those things are involved in a higher level processing of context, which helps a person know whether a perceived threat is real. And almost not too small there. There we go. So I'm throwing in some research just very, very briefly, and you can look those things up at the end if you want to. So this one is indirect acute effects of COVID-19 pandemic on the physical and mental health in the UK. And that was a population-based study, which means that there were lots of different areas that they looked at, from diabetes to heart conditions. And exposure started on the 23rd of March, which means we were really on track, because that's when we all started to be isolated. So surveys reported increased anxiety, depression, and self-harm during the pandemic. And exacerbations of obsessive compulsive disorder, severe mental illness, and eating disorders were also reported. They saw a sustained reduction in primary care. And I think that we recognise that in Northern Ireland, that there wasn't the same capacity. And then there was also a bit of overload because people were needing care for anxiety and depression and other mental health conditions. So there were reports in the whole of UK around those issues and concerns. And that's concerning because the majority of common mental health disorders are managed in primary care. And the observed reduction in healthcare contacts for people in severe mental health illness is concerning then, because those individuals are likely to be at greater risk of poor outcomes from COVID-19. So moms are not okay in COVID-19 is another study that was done, and there were 900 eligible women. Now, these numbers feel a little bit exaggerated to me, but I wasn't a mummy growing a baby and having little tiny people, so maybe not. But anyway, there were 520 were pregnant and 380 were in the first year of their delivery. Pre-pandemic, increased level of depression to 45%, and from 29% pre-pandemic levels of anxiety to 75%. And the lovely bit about that is that those results displayed marked reduction in severity symptoms where women engaged in the recommended 150 minutes of exercise per week. So it's not good for us to be alone, basically. It's not good for us to be stuck in a house or a flat or whatever and not be able to get out and about. So that's important to do exercise if this ever comes back our way again. This study was on depressive and anxiety symptoms through late pregnancy and into the first year, and examination of prospective relationships. So there are 159 women. Depression symptoms did not predict anxiety symptoms. And that's something that I'm playing with still, because you kind of think if you're depressed, you're likely to be anxious. But what that's saying is rather it's the other way around, that when anxiety is present so much in your body that you're more likely to be depressed. So anxiety is a predictor for depression symptoms. So I think it's because anxiety is such an energetic activity. It tightens all the muscles in your tummy sometimes. And it's hard to hold high levels of anxiety in your body. But anxiety and depression symptoms are modified again with social support in late pregnancy. So if parents felt supported, they felt less symptomatic. Maternal post-traumatic stress disorder in infant development, the developmental outcomes in a South African study show that maternal PTSD may be associated with impaired infant neurodevelopment. It's a very complicated theme and thought, isn't it? Because we feel bad enough as parents when we don't feel that we're in a good place, and we can feel, out of sync with ourselves so much. So, the very ordinary things about eye contact and the very ordinary things about making sure that there's a physical contact with the baby, those kind of ordinary, when you don't feel like it, doing it anyway, activities do make a huge difference to the well-being of your baby or children. Preventing post-traumatic stress disorder following childbirth and traumatic birth experiences. This was a systematic review. So there were 13 papers evaluated for the effects of secondary prevention interventions. So that's smaller things rather than, a system. So they talk about, our way of working to see if that way of working helped to ameliorate the PTSD symptoms. So this is a bit surprising, really, when you come to the end of this study, because no studies specifically evaluated the effects of interventions to prevent traumatic birth experiences. So it's a whole really in research, because that's the bit that matters, isn't it? Nobody wants to have a traumatic birth, and nobody wants to have post-traumatic stress symptoms 6 months later. And how can we prevent that? So I will address a little way. I don't have a lot of time, but I will try and bring some light into that. Multiple studies focus on negative birth experience, and that's true. And women attribute a traumatic birth experience to a lack of control and suboptimal communication and too little practical and emotional support. Debriefing has been shown to be effective in reducing PTSD responses, and that's because the mind is always looking for some kind of answer. And if you're bringing debriefing into a trauma response, it gives the mind a way to help the brain to help you to slow down those responses in your body. So presume if there has been an emergency that PTSD may result. That's really important. We get over emergencies because that's our job. You call somebody who's having a bleed, we stop the bleed. The mum's hasn't really come to terms with the fact that it happened before it's over. The emergency response will create trauma responses in her if she's become really frightened in that journey. And there's so many traumatic experiences that can happen in birth trauma in the in the delivery suites or in the home from home. In a natural active birth experience, it can be very frightening because you're on the switched on alert all the time. So you treat. Education takes PTSD and PTSD symptoms into account. You don't know. There's no way that you're going to know if somebody is traumatized at the time. They certainly won't know that those symptoms are going to be there later on. But there is no primary prevention of PTSD research. So we have to make it up a little bit. You got to know how it happens. We have to understand how that happens. How switched on fear response is still active 3 months later, and mom needs tools to prevent it taking hold. So research projects in the making, perhaps, for anybody who's interested. Should unqualified therapists, is a question I have, and I haven't got an answer to this, but an unqualified therapist as a counsellor, a psychological training rather than just anybody. And that should we be working with PTSD even though we have levels of training after birth unless they're qualified to work with primary trauma? And that's a study all on its own, because if you remove PTSD symptoms after birth, that might actually have a really good effect on primary trauma. But I find in my work that I'm surprised if somebody has high levels of PTSD responses that they don't have primary trauma. And that's because the brain likes to pattern match. It likes to bring things together. Prepare mummies, midwives in labour, seeing it ahead as a mystery to this mum, what happens next and why. Forceps, bleeding, emergency C-sections are obvious times when that could be prayer. Prepare the way and explain, prepare and explain again. Presume PTSD will be invisible until later. Bring down stress responses ASAP, and below are how to do that. Train women on the use of simple bilateral activities. Complete exercises from deep sleep to accommodate episodic memory consolidation with reduced trauma response. That first night after you sleep, a proper sleep, you're going into a deep dreaming space. And when you go into that deep dreaming space, the trauma is stuck unless it understands how to move. So if you're doing something that takes down the adrenaline response in your body or in your mind before you go into that first sleep, I expect that trauma responses would be reduced just by allowing the amygdala and the hippocampus and the parts of the brain which hold trauma will be able to experience that. And these are ways of doing that. You don't have to think up something. You just follow a little bit of an activity so that the adrenaline response is way out of your system before you go into sleep. So YouTube there, it's me. I'm there for 9.5 minutes going through 3 parts and another part to a 5-minute exercise. And that will get your adrenaline levels right down. There's no question about it. And Jerry Basic EMDR, Jerry saved my life as a young therapist in that I didn't understand trauma in the way that I do now. But he has a number of YouTube exercises. You stand a little bit back and you just sit very quietly and watch a balloon moving across the screen. And it's not earth-shatteringly exciting, but it is going straight into that part of your brain and helping it to calm down. Okay, the other thing is Mind Mental Health Charity looks at PTSD and explains it very, very well. And I didn't put all of those things up. I think that's me.
Thank you so much, Anne-Marie.
Okay.
It's absolutely fantastic. And as someone who's been through your service and been through birth trauma and the therapies that you provide, I can absolutely attest to the success of your model. I don't know if you remember this, Anne-Marie, but whenever I came to you after my eldest daughter Alex was born, and I told you that I was grieving because I couldn't have any more children, I couldn't go through it again. And 4 months after seeing you, I was pregnant with my second, intentionally, I should say. There's one thing that you said that I just want to pick out, and it was around the increase in depression with people who have anxiety and not the other way around, and that surprised you. And it was just whenever that came up on screen, it really didn't surprise me as someone who struggled with anxiety for a long time before I struggled with depression. So for myself, whenever I struggle with anxiety, it was, like you say, it was that energy of holding the anxiety for a long time. It was that constant living in fear and not knowing how to get past it. And that whole birth trauma and being re-triggered constantly, to the point where I think I just ran out of energy. And then the depression then kicked in at that point. And that's when I started, like you say, having suicidal ideations. We have a few wee comments here in the chat just before we wind up, because I'm aware we're at the end of our time. Pauline says, I've had sessions with Anne-Marie at the Ulster and she was incredible. I owe a lot to her. And Jen says, I feel like I've just had a therapy session just listening to Anne-Marie. Victoria says, fascinating presentation. Thank you. I'm sorry we can't get to any of your questions right now, but if you want to submit them to us at hello@theparentrooms.co.uk, we'll do our best to answer them after the conference. And maybe Anne-Marie, you might join me at another point and we'll do a little live video perhaps and go through it.
Yes, that's good.
Thank
you very much, everybody. Lovely to be talking. Wish I could see you.
Definitely. I know it's strange, isn't it, doing this virtually? But yeah, it's been great to have you, Anne-Marie. For everyone else, we're just about to take a short break. We're going to be back at 3 o'clock with Luciana Berger from the Maternal Mental Health Alliance. So we'll see you all then. Go grab a cup of tea and a comfort break, and we'll see you in 15 minutes. And thanks, Anne-Marie.
Okay, bye.
Bye.